Thank you. I'm, as well as National Clinical Director, I'm also a GP in Shropshire, and I'm going to talk about cholesterol and why it's important and why it's included in the NHS health check and what we do about it in the NHS health check and after the check and the pathway through primary care for the management of cholesterol. And I'm going to talk about what we know about how effective that process is and where improvement is needed, and a little bit about the improvement work that is going on at the moment. So if I could have the next slide, please. So I'm sure you'll all be familiar, if you're doing any work on the NHS health check, with this slide, which captures the whole process that takes place. And the red or orange colours at the top, you can tell that I'm colourblind because I'm not sure which they are, but those illustrate what happens during the health check intervention itself, and the blue at the bottom is what happens in the pathway that the health check represents, the pathway that takes us through primary care. And during the health check process, as you will know, information is collected relating to individual risk, so there's appropriate lifestyle advice and support can be given and appropriate further investigation. And one of the tests that is done is the cholesterol test, with a view to working out with an individual how much risk they are at of having a premature heart attack or stroke. Can I have the next slide, please? And so what we do about the raised cholesterol really depends on more than just the cholesterol itself, and the whole process is influenced by the NICE guidance, as you will know. And then could I have one more bit, please? So NICE advises us not to just go by the cholesterol levels, but to assess the 10-year cardiovascular risk score using Q-risk-2. And once we have that risk score, to explain it to people and offer them advice about the absolute risk that they're at and the absolute benefits that could be obtained. The next bit, please. NICE is also very clear that we don't jump in with statin therapy, and that once we establish that the risk is high, that we discuss lifestyle change with the individual and support them to make that change. And the next bit, please. And before offering them statins, if that lifestyle change is not in itself sufficient or if it's inappropriate for that individual. And the next slide, please. Now, this slide is taken from the recently published analysis using the global burden of disease data, showing us just how preventable premature mortality is. And these are the leading risk factors in rank order that account for premature death and disability. And as you'd expect, tobacco is at the top there. Almost 20% of attributable risk is due to tobacco. And if you could press the next two, please. Cholesterol there is at number 6. And high blood pressure, which of course is also a focus of the health check. If you take high blood pressure and high cholesterol together, that's 20%. That's equivalent to the impact of tobacco on premature mortality and morbidity. So these are important modifiable risk factors. Next slide, please. You will know there's been a lot of debate around statins and cholesterol, much of it in the lay press. Rory Collins published a really helpful, thorough, systematic review and meta-analysis a couple of years ago, identifying a clear level of benefit and harm for individuals. So if 10,000 people take a statin for 5 years, every 1 millimole per litre reduction in LDL cholesterol will reduce that person's risk of a heart attack or stroke or premature cardiovascular death by a quarter every year after the first year. So enormous gain. And every 2 millimoles per litre reduction for someone who already has cardiovascular disease, 1,000 events will be avoided in 5 years amongst those 10,000 people. And if it's being used as primary prevention, it will be 500 major events avoided. And one more bit, please. And Rory Collins also reviewed the adverse events. And as you can see, the numbers for severe adverse events are vanishingly small, extremely small. And one more press, please. But most of the adverse effects that are attributed by our patients and by the press to statins are actually no more common than with placebo. At the next slide, please. So how well are we doing in the NHS Health Check in management of cholesterol and high cardiovascular risk? Well, this was taken from a systematic, an evidence synthesis run by Cambridge University and published about a year ago. And this identified that there's enormous variation in whether or not people with a high cardiovascular risk get put onto statins. And it also uncovered that there's quite a bit of variation in people's understanding of risk following the health check intervention. Next slide, please. And this is mirrored in, I would say, confusion in primary care in the way that we manage high cholesterol. This was analysis done, published in the BMJ a year ago, using the THIN database. So 200,000 people on statins for primary prevention, 152,000 had a Q risk 2 recorded. So if we took all the people who were on statin, 3/4 of them had not had a Q risk 2 analysis done. And of all the patients who were on a statin who had a Q risk score, 17% of them were in the nice low risk category. And the numbers in the 10 to 20% and the above 20% actually were broadly similar. So I think, as I say, I think this reflects uncertainty and confusion and certainly inconsistency in general practice. Next slide, please. And it's not particularly surprising. Our clinical knowledge is very much influenced by what we read in the lay press as well as in the medical press, and by the impact of our patients' worries and anxieties. The Daily Express has taken a real interest in this, and the story is positive or negative, depending on which day you read. But whether positive or negative, no doubt this has created the impression of uncertainty about the value of statin treatment. And the next slide, please. And this has not been limited to the lay press, and quite a lot of academic articles have been published in academic journals, perhaps not necessarily the mainstream academic journals, but supporting, challenging the need for statins, supporting that we should start eating more fat and stop taking statins. This was a cut-in from The Guardian from a couple of weeks ago, showing that there is actually some talk of an academic fight back now, with academics pulling together to challenge the so-called cholesterol deniers and assert that actually the evidence for managing cholesterol is very strong. The next slide, please. But across the country, people have been struggling and are working hard to try and to improve our performance in management of high cholesterol and high cardiovascular risk. And many of you will know of the Bradford Healthy Hearts Programme. Could you press once more, please? Which took a real system-wide approach, identifying all the barriers that there were to treatment of statins, but also the other high CVD conditions, high-risk conditions like high blood pressure and atrial fibrillation. And by mobilizing the public and by mobilizing the clinical community, they managed to achieve 21,000 treatment optimizations, many of them improving people's treatment with statins. And in real numbers, this is not modeling, in real numbers over 18 months demonstrated strokes and heart attacks fell by 200 compared with demographically similar CCGs. Next slide, please. And just a few months ago, Litton and colleagues published a modelling study, a microsimulation study, looking at, could I have the next slide, please? Looking at if we improved performance in the NHS Health Check, what difference would it make? And they looked at, don't worry about all the figures on this slide, but it's just really the lower line I'm interested in drawing your attention to. And these figures show what happens if we were to increase by a factor of 2.5 interventions following the health check, so that the columns are statins, antihypertensives, smoking cessation therapy or weight loss programs, and at the end it's all treatments. And as you will hopefully be able to read from these slides, the impact of statins greatly outweighs all of the others put together at almost 10,000 life year gains over the follow-up period for this modelled cohort. So substantial impact if we could improve our performance in treatment with statins. Next slide, please. And one more. So just to finish off, to mention that we are undertaking a lot of work across the country now to refocus our attention on the high-risk conditions for cardiovascular disease, including high cholesterol, blood pressure, and AF. You will know of the Right Care CVD prevention pathway. This is going to become a national priority initiative for CCGs from next April, looking at how can we do things differently in order to optimise therapy. The long-term plan for the NHS is expected to be published in 2 or 3 weeks' time, and is expected to have a whole chapter on cardiovascular disease and CVD prevention. Public Health England, following that, will be publishing agreed ambitions for cholesterol and the other high-risk conditions. We are proposing a national CVD prevention audit for primary care called CVD Prevent, hopefully from 2019-20 if it gets commissioned. And this will draw down routinely held GP data with no data burden for GPs, but will illustrate to us on a daily basis where the gaps are, the opportunities in our treatment of the high-risk conditions, including high cholesterol. And finally, NHS Public Health England, in the last couple of weeks, has published a return on investment tool. Could I have the next slide, please? And this gives data nationally, but can also be used locally to show if we optimise treatment with statins or in the other high-risk conditions for CVD, how many events will we prevent and how much money will we save? And you won't be able to read the detail on this. It's really to show you the picture and to illustrate that statins is in there, that over about 20 years, optimising statin therapy would prevent approaching 300,000 cardiovascular events. But the bottom line is if we optimise AF, blood pressure and cholesterol treatment, that's how many strokes and heart attacks we will prevent over 20 years, and it's approaching 600,000. So an enormous impact, potential impact. And the next slide, please. And this is just to put some numbers on this and to show that if we were to optimise treatment of those 3 high-risk conditions, by year 5 we would have prevented 160,000 events, and by year 10, 310,000. You can see the savings in mortality and the substantial savings, financial savings to the healthcare system. So cholesterol is very, very important. It is clearly very important. We know that treatment works. And if we got a lot better at treatment, we would prevent many disastrous life events for individuals. But there is clearly substantial scope for improvement. I think the NHS Health Tech is an important part of our strategy for improvement. There is clearly more to be done. So I'll stop at that point, and I think we're taking questions at the end, but I think handing over now to Steve.
Thank you very much, Matt. That was terrific. So before we move on to questions, we'll go straight on to Steve Humphries, who's going to speak about familial hypercholesterolemia in particular, and then we'll go to questions. Thank you very much, Steve.
Okay, thanks Slade, and thanks Matt. So my first slide just gives you an outline of the things I'm going to cover, and I just particularly want to mention that the research that I've done over the last 30 years has essentially been funded almost entirely by the British Heart Foundation. So FH has got a number of key things, which I've just put up on the slide here. It's very common. We now have very good evidence that the frequency of carriers for mutations causing FH is about 1 in 270. So we predict more than 200,000 in the UK. It's very much underdiagnosed, particularly in the under 35 years group. And of course, those are the ones we want to find so we can offer them treatment. Because it's a genetic disease, 50% of children of an FH parent will have FH. So it means once we have an index case, we want to test their first-degree relatives, and that's a very effective way of finding more FH patients. It's associated with very much early onset of cardiovascular disease, And of course, early treatment with statins will reduce that CHD risk. And as we all know, statins are very safe and cost effective, as Matt has been showing us. But many of the identified FH patients are still being undertreated. So FH is a disorder of LDL clearance from the blood. The diagnosis criteria that we use in the UK are shown here, based on this Simon Broom FH register. So to have a clinical diagnosis of FH, an individual has to have total cholesterol, or specifically LDL cholesterol, above 4.9 millimoles in an adult. Levels in a child are slightly lower. And then a family history of either high cholesterol or early heart disease. And if they meet those criteria, they're given the clinical diagnosis of possible FH. And then the pictures below show that the stigmata of having had high cholesterol for some time. And if an individual has particularly tendon xanthoma, or obviously an FH causing a mutation, they're given the more stringent diagnosis of definite FH. There's also a Dutch lipid clinic scoring system and a US system. And the Dutch system in particular has been quite widely used in the UK.
Oh, excuse me, Steve, if I could just interrupt, sorry. Just to people on the phone and on Skype, it'd be great if you could please mute your phones and Skype, because it's very hard for us to manage at this end. So be grateful if you could please just mute phones and Skype. Thank you. Sorry.
So what we now know is that FH can be caused by having a mutation in one of at least 3 genes, either the LDL receptor, the ApoB, which is the main protein of LDL, or this novel protein called PCSK9. And what NICE did in 2008 and then updated in 2017 was look at all the evidence that we have and came up with a large number of evidence-based recommendations. And what I show you here is the front page of the implementation guideline, which was developed in conjunction with NICE, PHE, NHS England, and a couple of the charities. And here's just some of the headlines. The NICE guidelines is to lower LDL in FH patients by at least 50% from baseline. The European Atherosclerosis Society gives rather more challenging targets of lowering LDL. And then for diagnosis, all individuals should be offered a DNA test to confirm and to assist in cascade testing. Children should be tested if they're at risk because they've got an affected parent by the age of 10. And then systematic cascade testing using the DNA information is recommended by NICE. So you can see that knowing the family mutation is a key piece of information for cascade testing and for starting statin therapy in childhood. Now, the issue, of course, is why not simply measure LDL cholesterol in all these children? Wouldn't that be much cheaper and just as effective? And the answer is no, because of what we call the overlap problem. What I show you here is the distribution of LDL cholesterol in red in 5 to 15-year-old children who've got the family mutation, and in blue their brothers and sisters who don't have the mutation. You can see that there's 2 relatively distinct curves, but there is an overlap. And if you were to use that intersection point, you'd have a false positive rate of about 8%, a false negative rate of about 15%. And clearly, if we have a DNA test, we can work out exactly who's got the mutation and who hasn't. Now, that's what it looks like in the LDL cholesterol distribution looks like in children, but it gets much worse with age. The data I've just shown you is there on the left. And on the right, you can see that the mean LDL in the mutation-carrying brothers and sisters, essentially of the index case, stayed about the same. But the mean LDL in their non-mutation brothers and sisters has been creeping up as people get older, and we know that that's what happens. So now, using the intersection, we have a false positive rate of about 16%. More importantly, of course, a false negative of about 46%. So you can see that because of this LDL rising with age in non-FH patients, the overlap is increasing, and DNA testing is what you need to give an unambiguous result. Of course, if an individual has high cholesterol, you're going to offer them statin-lowering therapy, but what you really want to do is to know who in the family to cascade from, and clearly if you cascade from an individual who has high cholesterol but doesn't have the mutation, you're not going to find the number of affected relatives. So let me just spend a minute on presenting to you some information about how high CHD risk is in FH patients, and that it can be lowered with statins. And this is where we use the Simon-Broom register, and we compare the mortality rate in the FH patients on the register compared to the general population in the early period when there weren't statins available, in the middle period when FH patients were amongst the first to get statins, and then after 2008 when high-intensity statins became available. What you can see here is in definite FH patients, I've combined it, I've showed it separately in men and women, that pre-1992, the heart disease mortality rate in men was very high, over 3.2. It fell in the middle period, and in the most recent period, it's dropped very considerably, so that the SMR is about 56% lower. But you can see, although it's high initially in women, it falls then in the middle period. In the later period, it's actually as high as it was in the pre-statin era. And clearly, this is a concern. We don't actually know exactly what's going on here. It's possible that women are being treated later, perhaps after they've had children, perhaps with lower doses or perhaps with lower potency statins. But clearly this is a concern, and it's one of the things that we need to try to get to the bottom of and sort out. The point is that the risk is particularly high in FH patients because of what we call the lifetime LDL cholesterol burden. And what I've shown you here is the LDL burden. You can consider it like pack years for smoking. So it's the amount of LDL you have summed over your age. And what I've shown here in green is a threshold for clinical CHD when an individual in green, a 55-year-old non-FH person, reaches that threshold. The top line in blue crosses that threshold at the age of 35 years. So an untreated FH heterozygous individual develops heart disease about 20 years earlier than the general population. If you were to start statin high dose at the age of 18, you can see that on that curve there, that you cross that threshold of 48 years. So you would have lost 7 or so years of healthy life. If you however, if you start even a low-dose statin at the age of 10, you can see that line crosses the threshold at 53. So you're losing maybe 1 or 2 years of healthy life. And it's based on this sort of consideration that NICE recommends that statins should be thought of to be started by the age of 10 years to reduce the premature CHD burden. Now, a DNA test for FH from April next year will be offered by all 7 UK NHS diagnostic genomic hubs. They use a system called next generation sequencing to capture and sequence the exons of all of those 3 genes that I mentioned in one run. They can handle 96 samples in one go, and costs currently are about £250 for a test. And then once you've identified the test in an index case, you simply test for that mutation in a relative, and that's much cheaper. And from April the 1st next year, these DNA testing costs will be covered by the NHS. And this, of course, reduces the cost of the whole patient care pathway, at least for the providers and for the CCGs by a great deal. So the question is, how good are we at picking up mutations in these patients? In definite FH patients, we can find a mutation in about 80% of them. In possible FH, which are much more common in our clinic load, mutation is found in about 30%. So overall, the mutation is found in about 40% of those with a clinical FH. And the question has been puzzling us for many years. What's going on in the remaining 60%? And we put forward a hypothesis in 2013 that having a large number of common genetic variants that each raise LDL cholesterol by a small amount could mimic monogenic FH. And we published this paper in The Lancet, as you can see. We used 12 common LDL raising DNA variants, and we made what we call an LDL gene score. We compared the score in mutation negative FH patients from the UK compared to 3,000 healthy UK subjects. And what we found was a significantly higher mean score in the mutation negative FH patients compared to the controls. And we concluded that in at least 80% of the mutation negative patients, a polygenic cause of their elevated LDL is their most likely explanation. We've gone on in several other papers to confirm this in samples from 9 other different countries. And what we proposed in the Lancet paper is that only those with a detectable mutation should be given a diagnosis of monogenic FH, and the others should be called polygenic hypercholesterolemia. And then the updated NICE guidelines accepted that this was a very good distinction between the two groups. So here's just a cartoon to demonstrate this. This is a normal curve distribution of total cholesterol in the general population. And you can be above the diagnostic threshold for FH because you've got a pathogenic mutation in a single gene. And for this group, they have very high CHD risk, and you need to treat them with high-intensity statins and lipid clinics. And the alternative way of getting there is a combination of a greater than average number of common variants, each raising your LDL just by a small amount. And these individuals, as I'll show you next, have much lower CHD risk. And NICE agrees that the best way to manage them is to use Q-risk to estimate their CHD risk and treat them, as Matt showed earlier in this presentation. And this is a paradigm example of the use of genomic information to develop a precision medicine strategy for managing patients with FH. So it's important. The polygenic explanation is important because in the original guidelines, NICE said cascade testing should be done in all patients, whether you've got a DNA test available or not. But cascade testing in those with polygenic hypercholesterolemia is much less cost effective, and the NICE update says DNA test and only cascade from the mutation positive patients. We have shown that the polygenic patients have much less severe CHD, and therefore I think it's appropriate that they can be managed by statin treatment by GPs. And clearly, if we're searching for new genes that cause FH, we don't want to use the high score patients to be looking at because we know why they've got high cholesterol. And you may have heard of the 100,000 Genome Project, and included in that, 500 no mutation, low score FH patients are having their whole genome sequenced, and hopefully we'll be able to find some new genes in that group. So just want to spend a minute on some health economics modeling, because clearly it's important for NICE to know that cascade testing for FH is cost effective. So here's a typical family. The mother here in red is the individual who has FH. She attends the lipid clinic, and the FH nurse takes appropriate consent and sends a sample for a DNA test. Once the mutation is found, all 4 of her children are tested, and of course 50% of them on average will have the mutation, and they can be appropriately treated. And we demonstrated in a paper a couple of years ago that this is highly cost effective, and you can see the quality adjusted life year gains cost is well under the NICE threshold of £20,000 for an effective treatment. We then, when the NICE update, looked at how expensive it would be, how cost effective it would be to find new index cases by electronic searching of GP records. And the recommendations that NICE came up with is to search records for those at high risk of FH under the age of 30 with a total cholesterol greater than 7.5 and over 30 with a total cholesterol of greater than 9. And these individuals should then be identified and referred to the lipid clinic where the FH nurse can appropriately manage them. And again, the cost effectiveness in modeling was well under the NICE threshold. And of course, the point I want to make is that the health check program will find a large number of 40 to 70-year-olds who have their first ever lipid profile and therefore can be identified as possible FH if their total cholesterol is greater than 9 millimoles per litre. Just wanted to spend the last couple of minutes on children. There are about 7 million children under the age of 10 in the UK, another 7 between the age of 10 and 18. So we'd predict roughly 56 or so thousand FH children in the UK, and at most 600 are currently known. NICE says, as I've said, lipid-modifying drug therapy should be considered by the age of 10, and you should think about giving the child statin depending on their age of onset of heart disease within the family, and presence of other CVD risk factors. And the evidence that this is the age to start is based on a couple of studies from Holland, where using ultrasound, it was found that carotid intimal medial thickening in 10-year-old children with FH was much greater than their non-FH siblings, and in a randomized controlled trial using pravastatin, that thickening could be reduced over 2 years compared to those taking a placebo. And what we've done is to set up a children's FH register in the UK to collect Simon Broom type information on all the identified FH children in UK, update information annually with respect to growth, statin use and side effects. And our publications so far have demonstrated that statins are not associated with any effect on growth, and there are no reports of any serious side effects at all in the children on the register. So that really is very encouraging. So I'm just going to finish here. Public Health England have set out an ambition to find 25% of the predicted FH patients in England by 2023. This is quite a challenge. And in order to achieve this, obviously we need guidelines, clear recommendations and patient care pathways, and we have that. We need a network of lipid clinics where GPs can refer patients. And I show you here from the Heart UK site, there's over 130 clinics in the UK where patients can be referred. We need the accredited DNA testing labs, and we have that. We then clearly need paediatric service for the identified children, and here's the network of paediatric clinics that we've identified. And finally, what we need is FH nurses to take the detailed pedigrees, consent for DNA tests, and contact details of the relatives. And that's the part that is lacking at the moment. Currently, there are nurses that are covering about a third of the UK population, and we need to discuss very actively with CCGs to be able to obtain funding for nurses. That really is the key to success for this PHE ambition. And of course, what we also need is continuing cholesterol measurements from the health check in order to find the index cases that the nurses can then can trace their relatives. And I'll stop there.
Thank you very much, Steve, and thank you also to Matt for this terrifically insightful webinar on cholesterol. So we're just going to stop the recording, Chloe, if you could. Great, and what we'll do now is we'll take questions for Steve and for Matt. So we've got just under 20 minutes for that. We'll start with